Hi, I'm Dr. Henry Tseng. I'm an eye doctor at the Duke Eye Center. I'm also an associate professor of ophthalmology at the Duke University Medical Center, where I teach and do research. Today, we're going to talk about two important eye conditions, mainly cataracts and glaucoma. I'm going to start with some lecture style slides to give you some background, and then we'll finish with a question and answer session. In addition to English, I'm also fluent in Taiwanese and Mandarin Chinese. But because of the interest of time, we will focus and do the slide in English. But I'm happy to answer questions later in any of the other languages. I've also included some Chinese characters, so folks could follow along in both English and Chinese. Let me start by giving you an introduction of my educational background. I went to college at Stanford University in California, and after graduation, then I moved across the country to the University of Pennsylvania School of Medicine, where I did my medical and research training, my MD and PhD degrees. I also stayed there for my internship before moving down to North Carolina to Duke University. This is where I did my ophthalmology residency and an additional training as a fellow in glaucoma. And after I completed all my training, I joined the faculty and have been here ever since. And that was more than 13, 14 years ago. So when you have an eye problem, who do you see? Who do you see for cataract and glaucoma treatment? And who do you see to get contacts or just a new pair of glasses? So this is a common confusion among patients. And that's because the word eye doctor actually refers to two different professionals. So the first professional is the ophthalmologist. The second is the optometrist. And so what's the difference? Well, just a quick background here. An ophthalmologist is an eye doctor who's a physician. That means they went to medical school and they're trained for medical and surgical treatment of eye diseases. And another source of confusion is the word doctor. So the word doctor is not the same as physician. The word doctor just refers to someone with an advanced degree. So for example, a PhD in art history also is a doctor. So who's an optometrist, or what is their training involved? Well, they're not a physician, but they do. They have received extensive training for doing eye exams as well as prescribing and making glasses and contacts. They typically do not do laser procedures or eye surgeries. However, they could do general annual exams as well as specialized testing. So how can you tell the difference? Well, number one, you can ask them for their degree. So an MD is a medical doctor and an OD is an optometrist. And so typically, if you look at their card or their professional name tags, it should be written like, here's the name, Dr. John Smith, but then MD at the end, or John Smith, OD. Then this way you can tell if they're an ophthalmologist or an optometrist. Sometimes it could be confusing because often they may not have the degrees in the back. Sometimes they'll just say Dr. John Smith or John Smith eye doctor. And so if you're not sure, it's okay to ask the eye doctor what their background is. So just a little bit more background before we get into cataracts and glaucoma. I just want to quickly go over kind of a basic anatomy of the eye. This way you'll know which part of the eye I'm referring to. So think of the eyeball like a camera, like the webcam. Light goes in through the front here, and there's a clear part called the cornea, and then there's a little space between, and then there's a little small opening called the pupil. And the pupil is formed by the iris. In some patients it's blue, or in others it's brown. And then behind this sits a lens. Just like a lens in the camera, this lens is clear and it helps to focus light onto the back of the eye, the orange part of the eye here, and that's called the retina. The retina is like the sensor or like the film in the camera. And once an image is formed by the retina, then it gets sent to the brain. The brain is way back here, through the optic nerve. So the nerve is very important. The nerve is like a cable between a camera and a computer. And these structures in the eye are extremely small. So usually without a microscope, one cannot really see enough details to make a diagnosis. And so when you come to the eye clinic and receive an eye exam, we typically use a microscope that looks like this. And we can then look inside the eyes with a lot more detail. Okay, I think now we are ready to talk about what cataracts are and what we do to treat cataracts. Let me direct your attention back to that cartoon of the eye. And if you look at the eye anatomy, there's a structure here in the center called the lens. And the lens is just like the lens in the camera. Light comes in through the front and gets focused by the lens into the back of the eye, which is here. This is the retina. The retina functions like the film or like the sensor in a camera. And obviously to get the perfect picture with the best color and sharpness, you want the lens to be nice and clear and able to focus perfectly onto the back of the eye. So what is a cataract? So on the left here, this is just a cartoon to illustrate what a normal eye looks like. And here's a normal lens, and it's nice and clear and normal shaped. And often with a microscope, in the pupil, you don't see anything, because it's crystal clear and it's transparent. And when we look inside the eye, we can get a beautiful view. A cataract, in contrast, is when the lens itself gets larger, gets cloudier. And this is a little exaggerated, of course, but when you look inside the eye with a microscope, you can actually see the cloudiness and you can see the changes in the lens material. And this is what we look for during an eye exam. And unfortunately, as the material gets cloudier and cloudier, glasses sometimes helps a little bit, but it reaches a point where glasses will not help anymore. So what does a cataract do? Well, mainly the cataract, the cloudiness in the lens blocks a lot of the light. So light can't get through, and so one of the main effects is, at night when you're going out and when you're driving at night, you need more light to see, and without more light, it's harder to see the road signs, to see details on the road. And when you're reading in the house, you'll have to turn up the lights more to get more light into the eye and past this cataract. Cataract, because it could also dull colors because the material itself may become brown. And you can see here in the left, if you have a normal lens, the color is very vivid, but with the cataract, the color gets dull, and sometimes the colors are off. Cataracts also cause blurriness. It doesn't have to be in the center, but here's just an illustration to show you what cataract effects are like. So details will not be as crisp. It may be here, it may be to the side, or it may be the entire field of view. But typically, one could notice the blurriness get worse and worse, and small details and fine prints are harder and harder to see, despite updated glasses. So how is cataracts treated? Well, early on, when the cataracts are mild, one could just update your glasses, and eventually you'll get to a point where glasses will not help anymore. And when glasses won't help, and you're having trouble driving and reading and doing what you need to do daily, one would basically need cataract surgery. What is cataract surgery? Well, it's when we go into the eye and remove the entire cloudy lens, and then replace it with a small plastic lens implant. And here's just some examples of these small lens implants. These implants are made from plastic. They last forever, and it's a marvel of modern technology. This is flexible plastic and very tiny. So look, in comparison, this is a dime, okay? So look how small these things are. And we're able to implant these into your eyes during surgery. So cataract surgery used to involve cutting open the eye completely from one side to the other side. But with improvements in technology, we now operate through small incisions. We make small little holes that are very tiny, and then we place instruments into the eye, and we use ultrasound to break up the cataract into even smaller pieces, and then we remove it by vacuum aspiration. And then once we remove the cataract and completely clean up the area where we were operating, then we could put a small intraocular lens implant like the ones I just showed you in the previous slide. Some even newer technology that we do now is to use a laser. It's called femtosecond laser. And what this does is, instead of a knife, we're actually using a laser to do all the cuts inside the eye. And we can use this to also do some vision correction as well. This is very precise, very fast, but unfortunately it's not all covered by insurance. So this sometimes involves a little out-of-pocket expense. Another area of excitement are new implants. So the traditional implant that's been used for the last few decades only corrects for distance vision. But now with newer implants, we could correct pretty much everything. We could correct astigmatism, and this part is very exciting. We could correct presbyopia, or basically vision up close, when we can't see and you have to use reading glasses. So we could correct that part now, as well as myopia and hyperopia. So in a sense now, cataract surgery is not just removing the cataract, but also we're doing vision correction. So in the past, one needs to stay in the hospital after cataract surgery, but that's not true anymore. Nowadays, it's what we call outpatient surgery, which means you come in, we do the surgery, and you go home the same day. You just typically need to wear a shield and then take some precautions. Usually we don't need a suture anymore. The incisions, the openings that we made are typically small enough that they will close up on their own. And so we rarely now use stitches to close up the eye. You may need one or more eye drops after the surgery. Even this is changing. We're moving towards what's called dropless surgery. This is a new development where we could use a medicine implant. And the implant is very, very small. And this picture illustrates that. The implant goes into the drainage tear duct of the lower lid. And after we finish the cataract surgery itself, we just push that in right there. It doesn't hurt. And what that does is the implant slowly releases medicine over the next few weeks for the eye. And so by doing this implant, one does not need to do eye drops. And that's important because after surgery, it's hard for a lot of patients to accurately put eye drops into the eye. Right now, not all insurance will cover this. So depending on your plan and depending on your Medicare coverage, some patients will either get this or may still just need one or two drops. So next, let's talk briefly about what glaucoma is. Glaucoma is actually a very complex disease. There's many different subtypes depending on the cause of the glaucoma, and some we never know what causes it. So typically when you come into the clinic, we will do an extensive series of testing to determine your status, to see how much vision you've lost and what might be causing it, and that will help determine how we treat the disease. And by the way, January is Glaucoma Awareness Month. So it's quite meaningful for me to be talking about glaucoma and sharing information with you. And glaucoma is one of those diseases where one needs to be diagnosed early and treated, because once vision loss is gone, or once one has become blind, there's no way to bring back the vision. The vision loss is irreversible. So the earlier one's diagnosed and treated, the better. And the most recent statistics estimates that almost 3 million people in the US have glaucoma, and half, if not more than half of them, don't even know it. And that's scary, and they're slowly going blind. Most of the glaucoma subtypes do not have any symptoms, and when it's early, it's hard for patients to notice the change, and there's no pain necessarily. So historically, doctors thought that glaucoma was only caused by high eye pressure. But with a lot of research recently, it turns out that this is not true. In fact, most patients with glaucoma have normal, if not low, pressures. And this is especially true in Asia, where more than 80 to 90% of glaucoma patients have low or normal pressures. And the same thing with Europeans. So what is glaucoma then? Well, the definition of glaucoma has changed as a result of all this research. And the current definition is when there's optic nerve damage in the back of the eyes. And when the optic nerve is damaged, signals from the retina and the eye cannot get to the brain. And that is how vision is lost. And this glaucoma nerve damage could be fairly slow and could take months and years. And because it's so slow, it's hard for patients to notice the change. And there's typically not a lot of pain or other symptoms that you can notice. Often you just start with some visual field defects, which means you lose vision, side vision in the periphery, as well as possibly in the center. But because the brain is so good at compensating for small amounts of vision loss, again, most patients do not realize they're losing vision until it's too late. And then ultimately, glaucoma could get to a point where one could be completely blind in the eye, meaning you don't see any light at all. However, even though many patients have normal levels of pressure, the only thing we could really treat at this point is bring the eye pressure down. And just a little background about eye pressure. So the middle of the eye here is filled with jelly material, but near the front, this is actually filled with sort of water-like fluid. And then the water-like fluid drains through this tiny structure right here in front of the iris and behind the cornea called the angle. This angle could be blocked, could be open, and through those findings, we actually could classify glaucoma into two main types. And ultimately, if the fluid's not draining well, then the pressure is transmitted to the optic nerve, and pressure pushing on the optic nerve then causes damage over time. And that's the only type of glaucoma we could really treat at this time. And when the angle is open, we call it open angle glaucoma. And this type of glaucoma is the main type of glaucoma. It's very chronic, very slow and chronic. And because it's very slow and chronic, most patients have no symptoms. Most patients don't realize they're losing vision. There's really no pain. But the other type, the other main type, is called angle closure glaucoma. This is the one subtype of glaucoma where one could actually have symptoms, where the eye hurts, you feel nauseous and start vomiting, and you get a headache, and maybe your eyes turn red, and you can see halos around light sources. If you have all these symptoms all at once on the same side of the eye or the head, that may be a sign of acute angle closure glaucoma. Fortunately, this is very rare. But when this does happen, it's an emergency and we need to treat you right away. So what does glaucoma visual field loss look like? Well, so if you look at this beautiful structure here, normally you can see the entire building, it's a very large building, and you can see the central part, you can see the periphery. But with glaucoma vision loss, you slowly could lose the side vision and you lose details in the edges without realizing it. And then that loss could get worse and worse. And as you become a more tunnel vision, you start to realize, whoa, I'm not seeing the whole building now. I'm only seeing a small area. And if this is not successfully treated, then one could go completely dark and lose all vision. So this is what typically, glaucoma involves, usually peripheral vision loss. But with exception, in some patients, sometimes the visual loss starts in the middle and then expands outward. So how do we treat glaucoma? Well, so the strategy for treating glaucoma is to diagnose and catch glaucoma early and then prevent loss. Because once vision loss has occurred, we cannot restore vision. What's gone is gone. So you have to catch it early and then try to minimize and prevent loss. Unfortunately, there's no cure. So what that means is we cannot get rid of the disease, but we could just control it with these treatment. So the most important thing is one needs regular exams. Even with successful treatment, things could change rapidly, and the only way we could detect these changes is through regular exams and testing. Typically, early on, we treat glaucoma with medications. There's all sorts of different eye drops one could use now to lower the eye pressure. And then often, if one doesn't do well with eye drops or had trouble putting eye drops in, or if the cost is too high over time, I typically recommend laser treatment. Laser is actually pretty gentle. There's many types of laser treatment for the eye. This is not the type of laser for correcting vision, but this is a type just to lower eye pressure. So it's very gentle, and we do it in the clinic, and it's typically covered by insurance. Now, if medication and laser treatments are not successful, then we may have to go to actual surgery, where we implant shunts into the eye, create drainage ducts, and alternate ways to get rid of fluid. Of course, the incisional surgery option is riskier and is more involved. So we typically reserve that for patients who absolutely failed medications and laser treatment. And as part of glaucoma treatment, the most important, again, for me to emphasize is follow-up exam. I've seen patients where they come in for a checkup, get diagnosed, start on the treatment, and then don't come back for years. And then by the time they come back, they lost even more vision without realizing it, even though they're still using eye drops. Because sometimes one drop is not enough to control the eye pressure. Sometimes you may need more than one, or sometimes the pressure still goes up and the patients don't know. And then at the same time, at these follow exams, we will do visual field testing. There's standardized, computerized visual field testing that could map out your vision and then compare changes over time. Another new technology we use now are optic nerve scans. It's a picture and computerized scans of your nerve itself. And then when we do this over time, we could compare the different test results to see if there's any nerve loss over time or any major changes. So combination of all of these are very important for glaucoma treatment. At this point, I'd like to stop and save some time for questions. I'll be happy to answer any questions you may have on cataracts and glaucoma. I'd like to thank all of you for your time and attention. And I especially want to thank our organizers for their hard work and the opportunity to share this important information with all of you. So thank you all.